Welcome to this live staff wellbeing webinar for IAPT service support during COVID-19. I'd like to thank our sponsors, ICS Digital Therapies. We at SBK are really proud to be delivering this event, and I hope that you find it useful. It gives me great pleasure to introduce Dr. Sarah Watts, Consultant Clinical Psychologist, and Brian Rich, Senior Cognitive Behavioural Therapist at South Staffordshire IAPT Service.
My name's Sarah Watts. I'm the clinical lead with the Staffordshire and Stoke-on-Trent Wellbeing Service, which is the IAPT service across Staffordshire and Stoke-on-Trent, and I work across the South teams.
And I'm Brian Rich. I'm a Senior Cognitive Behavioural Therapist with responsibility for the long-term conditions integrated pathways across the South Staffordshire teams.
We've been really overwhelmed by the response to this webinar and the number of people who have shown an interest and have signed up today. And we were also rather overwhelmed to find the list of learning objectives that was sent to us in advance in terms of what people wanted to get out of the webinar today. And we've been trying to think very hard about the best way to answer some of those questions and the best way to give people a framework to think about what's happening at the moment in the very difficult and unprecedented times we find ourselves. And we've only been given 40 minutes to do it in, which has been a bit of a challenge. So rather than try and answer all of the questions, what we've tried to do is to put together a structure and a framework that we hope will help people try to identify the issues in their own area and work in a similar way to the way we've worked in South Staffordshire to solve some of the issues you find in your own localities. So our aims for the session, as far as we think they will be helpful, are to share this framework for thinking about staff wellbeing within this environment that has higher than usual levels of stress and many competing demands on all of us as managers and leaders, as clinicians, and also on our patients. We're going to consider the different phases of the current situation and look at the strains on people's wellbeing that may come at each point. Now we're going to share with you how we've applied this thinking across our services in South Staffordshire in terms of supporting our staff as they continue to support our local communities. And what we also want to say as well is we're not the experts in this. We're human too. We're not perfect. We don't have all of the answers, and neither will you have. And I think what we also want to start to discuss this afternoon is the fact that we will get things wrong. All of us will get things wrong as we go through this process. And I think keeping the channels of communication open and being able to adapt and flex our approach on a daily basis as needed is really important as we move through these current difficult times.
So what we know is that the impact of coronavirus has been and continues to be severe. It places huge strain on all NHS services trying to cope with the multiple and massive consequences of the disease, many of which are only just coming into focus as we deal with this crisis. It's important to remember that no one's unaffected by the virus and the fear that it creates. The fear that's created among communities, healthcare staff, professionals and managers, all of which causes severe psychological strain. We're all trying to get our heads around the crisis and try and make sense of the crisis as it's unfolding, while simultaneously trying to contain the fear, the pain, the loss or the uncertainty that we have in our own lives or the lives of loved ones, whilst trying to support our colleagues and patients and still deliver good psychological services within limited resources. The difficulty is that these kind of emotions can prompt immediate action, but with competing pressures and interests that pull us in different directions. And this then sets off conflict within us and between us, and risks creating distress and unhelpful or ineffective responses. The problem is that we know from evidence of past pandemics and epidemics that the psychological toll is likely to be long-term and significant. In fact, in the Lancet yesterday, there was an academic paper highlighting the scale of the problem, both now and in the future. And there's an urgent call for research initiatives to think about and better understand the wide-ranging and long-term mental health implications of this crisis and how services can adapt and respond. so that we know that at some point that the front line is going to shift from physical health settings in hospital wards to mental health services like IAPT. So whilst we talk about unprecedented pressures, it's important to remember that IAPT services are, of course, well placed within our communities to help deal with some of the problems, offering free, accessible and effective therapy treatments on an unprecedented scale itself. So actually we offer a message of hope, and we have an important role to play. And whilst our colleagues on the physical front line are working hard to preserve and support a biomedical wellbeing and recovery, it's vital that we play our own role in supporting them with support, insight and tools to help them bear their distress as much as possible now and in the future, as well as trying to serve the needs of the public now and in the future. The key aspect of all of this is that the physical and emotional well-being of our colleagues and communities is inextricably bound up with the well-being of our own IAPT staff and the staff in other mental health services. There is research from past pandemics that might help us to make sense of what might be important in terms of staff well-being. And there was a study that was undertaken by Perrin and colleagues reviewing evidence of the SARS epidemic and pandemic, which identified a number of key factors that were linked to resilience of healthcare workers. And whilst this related primarily to physical health care workers, we believe that the insights offer valuable evidence for ourselves. Some of the insights involved staff having clear directives from managers, clear messages that were then adhered to by staff. Staff also needed to know that they had the ability to give feedback to staff, to managers, and be supported by their management. So if managers might sometimes get it wrong, we need to know that staff have the confidence to feed that back to managers so that we can then think again. We know that it's important that staff feel well equipped, not just in terms of protective equipment on the front line, but also in terms of IAPT services having the right technological equipment and other resources to do their work. It's also important that there's regular support from colleagues and families, and these are often tensions that we'll talk about later. But the staff need to know that their families are supporting them and also that their colleagues are in touch, particularly when home working. Often staff may want someone to talk to, but often staff may not. We know that sometimes encouraging people to talk about crises mid-crisis can actually be harmful. But we also want to know that for staff that need it, there's the availability to talk with someone if they need. And then at the heart of this is the need for staff to have a perception that their own role is important. Everyone wants to know that they're doing their bit, and it's vital that we ensure that every member of staff, whatever grade, whatever role, whatever modality, are clear about how they can contribute in the current situation. Of course, what's interesting from the research is the recurring theme of relationships as a source of resilience. And this is something that comes as no surprise to psychological therapists of any modality. We know that in any supportive relationship where one feels listened to, it's an essential aid to well-being and recovery from any psychological distress. But we also know that relationships on their own are not sufficient for well-being, and that often other things are necessary, and all modalities recognise the importance of focused and meaningful thinking as a part of those relationships. Thinking that has a role in containment of overwhelming emotion. Thinking that nurtures psychological development and growth so that conflict and distress can be tolerated, processed and worked through. And thinking that uses experience and evidence to plan effectively. The difficulty, of course, is that during high periods of pressure and persistent anxiety, both relationships and these vital thinking functions can be placed under immense strain, and that then puts psychological and physical well-being at risk. So we wanted to use a model that might be familiar to many managers or supervisors and indeed many staff, which is a seven-eyed model for helping professionals, which was developed by Robin Shohut and Peter Hawkins. And we believe that the model is quite useful for trying to make sense of some of the difficulties we have, because it places relationships at the heart of the model. For those unfamiliar with the model, we'll briefly explain it now. It's a model that helps to think about and understand the complex interactions that take place within helping professions and try to ensure that no part of the system or the relationships within it are overlooked. So in the model, that part one is about the client, but we might think, who is the client? So it might be patients on a hospital ward, clients in therapy. It could be the community as a whole, since we know that stress, anxiety, depression, domestic violence is all increasing. Or it may be about future clients. It may be about healthcare staff who will become future clients to us. And it's also about the levels of problems or the distress brought. Number two is the type of helping relationship offered. IAPT offers a range of evidence-based therapies, all of which are going to be vital in dealing with the effects of the crisis. The therapist or the health professional is number three, and that includes their role, factors such as their own vulnerabilities, such as long-term conditions, their own fears, and their emotional well-being. Four is the nature of the relationship between managers and supervisors, and that might include team meetings, supervision, briefings, or other vehicles for communication. Number five is managers and supervisors, their roles and factors affecting them. Of course, they're also experiencing personal fears and under professional strain. And the one thing we'd like to mention here is that there is a role, even though that's at the top of the diagram, there are higher levels of management, and managers, we believe, need to have the courage sometimes to speak up to higher levels of management and ask them to stop and think if they believe that decisions might be harmful to the relationships within their team or to the client group that they serve. Number six is the influences or pressures on organisations or the helping services offered, and we've put a number in there that's not an exhaustive list, and that's one of the problems that people face, is the sheer number of different competing pressures. And then number seven are the other external factors, such as the economic realities of services or the impact of coronavirus itself. In keeping with our perspective, the model is both systemic and relational and can be adapted to think about pressures on staff and services at this time. Within the nature of the relationships, there's also a focus between them, trying to think carefully together about the problems that people are facing, but that takes place within distinct boundary work. Crucially, the reality is that any changes or decisions to practice that affect one part of the system affect all parts of the system, and often in not helpful ways. Thinking then about both the structure and the boundaries around the relationships. At the structural level, there are concrete practical issues. So that might be the environment where the work is taking place, the equipment used to facilitate therapy or supervision, team meetings or training. Also have channels of communication internally between staff and then between organisations and partner agencies or bodies. But it's also about other boundaries. It's about boundaries between clients and therapists, between home and work, and breaks within work. It can be used to think about team structures and the relationships within them. But if structures become excessively damaged, then that's when the trouble begins. And so the structure and the bonds within them need to be strong and robust, whilst flexible to adjust to changing circumstances, so that we provide a holding space that supports the focused thinking. In terms of focused thinking, it might be stating the obvious, but as therapists we know that not all thinking is helpful or healthy. Mental activity itself is not to be confused with psychological well-being. And without meaningful focused thinking, the ability to cope with emotional pressure and grow psychologically will not occur. Each decision we make or action we take is a precious use of our time and resources, and so should be based as much as possible on holding and containing the tension between competing pressures so that effective work can continue. So some of the types of thinking that we think are important and that are based on lessons learned from past research are: what are the immediate pressures facing our team now, and what are those expected in the future? What's the best that we can do now and with what we've got available? What messages and directions are most needed by therapists now at this particular point in practice? So that's about not overwhelming staff with issues or information that they needn't be preoccupied with. So are people clear on their role and how they can help? Do staff feel equipped to discharge their duties safely and effectively? And where we might face resistance within a team, it's important to question that term resistance and think behind it and wonder if it's indicative of an anxiety or a concern in that member of staff, or whether it's a communication to us that we may need to stop and think again because we may have got it wrong. We might need to think about any decisions we make and whether relationships are strengthened, strained, or damaged by those decisions, and whether we can mitigate any of those damaging effects if they take place. And then we need to think in a creative way, so we need to try and encourage creative thinking about positively adapting to the problems or pressures. And then lastly, when we make decisions, we need to review them and think, well, how have we done? What's gone well? And are there mistakes that we can learn from or repair? The thing about focused thinking, in our view, is it's important that the quality of the thinking actually strengthens and protects the integrity of the structure, just as the structure protects the integrity of the thinking.
Okay, so what we thought it might be useful to do next would be to have a look at a model of working through a major incident and look at the 3 different phases and then apply to that what we've actually done in South Staffs, not to set it up to you as us being the experts and us knowing what to do, but to just let you know what we've done and to give you some ideas that may be useful for you to use in your own services. I think based on the Shoei and Hawkins model, I think what comes to my mind really is that where there are no boundaries for people, there tends to be chaos, and where there's chaos, there tends to be anxiety and fear. And that can be the same for our staff as it can for our patients. And if we're expecting staff to help and support patients and other potential healthcare worker colleagues who may become patients, we have to ensure that our staff feel safe and secure and supported within those boundaries as well. So as leaders and supervisors and managers, it's our job to ensure that our staff are well supported and that their well-being is supported throughout this process so that they can continue to do their jobs within these boundaries. So the 3 phases that we're going to talk through are the phases of preparation, the active phase, and then the recovery phase after the peak has come. So the preparation phase is very much initially about shock for people. Everything that we knew before in the world has suddenly changed, and very suddenly in some cases. And everybody's initial concerns turn to themselves and their own loved ones, which is the obvious thing that we will all do in that situation. But included with that as well, there may be some issues around clarity of role, clarity of how people will continue to do their jobs when everything's suddenly changed. Fears about what might happen in the future, what might be to come, and uncertainty. And perhaps some worry about what they may be asked to do and whether that will be significantly different to what they've been doing previously. And within that as well, we're all human beings. We're all going to be asking, will I be good enough? Will I be okay? And who's going to look after me while I'm trying to do this? So that initial preparation phase is very much about the self and our own loved ones. And I think the concern within that is that individuals within a system will go to that way of thinking, but the leaders in the system have to look after the individuals within it, but also think about the wider team and the wider system and the wider service. And this is sometimes where differences in opinion can occur, perhaps, between members of a team and the people leading it, where decisions may have to be made that may not always seem to be logical or sensible or straightforward to other people who are being asked to enact them. And I think an example of this that I know several services have had, because I've had conversations with other leads about it, was the initial move to home working when we were first told that services needed to move to working remotely. And obviously everybody wanted to be safe and everybody wanted to go home straight away, but there were some factors that had to be taken into account around this. Not all services had enough kit to give people technology to take home and start working straight away. Obviously, there were priorities of people to try and keep safe. So for people who are pregnant, for people who have their own underlying long-term health conditions, they had to be safely moved home first and had to be ensured that everything would be in place for them to stay safe and to continue working. And sometimes that's difficult for other people to understand if they don't fit into those first categories of people that have to be moved out. So I think keeping those lines of communication open between leaders and managers and the staff to explain why things are happening and how they're happening is important. Although sometimes that can be extremely difficult to do when things are having to happen very, very quickly, as they have throughout the last few weeks. Moving people out to home working as well isn't as simple as sending them home with a laptop and a phone. You have to ensure you've got infrastructure in place for them. You've got to ensure that the supervision is set up and that needs to be more regular, because when people aren't in an office and they're not seeing each other in the kitchen when they make a coffee, or they're not able to have a bit of a chat in between patient sessions to just talk about how things are going to support them, it's actually much harder to be sat at home on your own all day seeing patients and not having that informal support of colleagues throughout the day. So making sure that supervisors and leaders have capacity in their diaries to have virtual meetings and ad hoc sessions with staff to make sure they're feeling well supported is really, really important. And that all has to be organised at a very early stage. Most offices are continuing to run on a skeleton staff, not all, but there are some staff who, for their own reasons, may want to have more support or may need to have more support. And it's thinking about if there are skeleton staff operating in an office in order to perhaps staff telephone lines or do various other essential pieces of work that have to happen from the office, thinking very carefully through who those people might be and what support they will receive in the office if they're continuing to come in. I think for me as a clinical lead as well, people's competencies and issues of quality can't be ignored at a time like this. I think we're probably all relieved to a certain degree about the amount of red tape that we have been able to drop in the last few weeks in order to focus on our patients and our staff and get things done. But actually we still have to retain the evidence base. We still have to make sure people are working to a certain quality and within their competencies. We shouldn't be asking people to do more that's outside the boundaries of what they're able and qualified to do. And we need to make sure that people have got what they need in order for that. So thinking about ad hoc meetings, potentially, we've started doing some drop-in meetings where we have a senior supervisor or manager online for a couple of hours and people can drop in and out of that meeting on MS Teams to either come and discuss a case or say hello or catch up with their colleagues. It's really important that people have those times to debrief where you can also be keeping an eye on what they're doing and making sure that they're not being asked to do or feeling that they need to do things that are over and above their usual level of work. In terms of IT support, we've had fantastic support within our trust. We're operating using MS Teams for team meetings and briefings and supervisions. We've got telephone and video platforms set up for patient work. And I think everybody's had to adapt very, very quickly to using those. I think most trusts have had a fantastic IT response in terms of getting systems set up for people. Sometimes the challenge, though, is actually getting people to use them. And you can have the best systems set up in the world, but sometimes people are reluctant to use them for various reasons. And I think what we've learned is that the people who don't log in to the sessions that are set up, or perhaps don't arrange to meet with their supervisor as regularly as we'd like, we need to make sure we're following those people up and they're not feeling left out just because they're finding the technology difficult. I think in terms of the structure as well, something we did very, very early on in the process was to set up a leadership team WhatsApp group. And that's been really important for me to keep an eye on the managers and the leaders in the service and make sure they're okay. And we use it after everybody's gone home at the end of the day just to check in with each other, make sure we're all okay, see if anybody has had a difficult day and needs any support. And that's really important because we can keep a strong structure going then within our leadership team, which enables that leadership team to continue to support everybody else in a strong way. The second phase then of this model is the active phase. And as we were talking about this, we felt that possibly there are two parts to the active phase. because at the moment our physical health services are obviously under very, very high levels of demand, and they're in a very active phase of this. But mental health is slightly behind the curve in that respect. And although we are actually seeing some referrals come in, certainly within our service in South Staffordshire, we've had less referrals coming in over the last couple of weeks, which we think may possibly be a feature of lots of people being at home and maybe not able to find a confidential space to call. Or it may be that they have other physical health concerns that are currently more pressing, and actually their need for mental health services and IAPT will come a bit later. So in terms of the mental health front line, we're experiencing some of that now, but we actually think that may come much later for us after the peak of the physical health curve, and possibly for several months and even years after that, in terms of the effects that it may have had on people in their psychological well-being. And that will obviously include our staff as well as our patient group, because we can't move the two apart from each other there. We're all human, and we're all subject to the same fears and the same concerns as our patients in terms of COVID. So this second phase is an intense, consuming and prolonged process really over several months. There's a potential loss of boundary in here as people work from home. They may be working within the context of their families being with them at home. They may be having to work different hours because, for example, initially within our trust, not everybody could log into the server during working hours. So some people have been asked to work at different times of the day or over the weekends. So those boundaries of usual working hours may have changed, and it may actually be quite difficult to switch the laptop off at the end of the day if you feel that other people are still working. There can be an expectation there that you should still be working until later in the evening. And I think it's really important. I certainly have an email signature that states I may be working outside of usual office hours, and I'm not expecting a response until people are back at work. If I end up working into the evening, that's my choice, and it's not an expectation that the rest of my team should be doing the same thing. There may be a tendency in people to either make a step up and want to do everything they possibly can to help, or there may be a tendency to step back because they don't want to be part of the front line. And I think that again can lead to tensions within a team, possibly where people may feel irritated with people's differing responses to what's happening. And I think as leaders and as managers, it's important for us to encourage compassion and kindness at that stage, and encourage people to understand that we all have our own individual situations, and we shouldn't be judgmental of each other and how we're operating within that. I think the move from the preparation to the active phase may be described as a move from focus on me to focus on we. And I think the we becomes the team and the wider community at this stage, and us as part of a wider system and what we need to do. And this is where it's really important we keep our staff connected with each other and with us as we move forward, so that they have a sense of being part of that wider team and not just an individual person working in isolation at home. There may be concerns about performance because there are less opportunities to check in with people about how we're doing as therapists. So again, keeping that communication phase open is really, really important. And there are concerns for some people about redeployment. We have heard of some IAPT services who've closed to new referrals and redeployed staff. We know that's not been the national guidance, but in some places it has had to happen for various reasons. And I think there is an anxiety amongst the workforce of, is that going to happen to me? Will I be called to do something else? Will I be moved somewhere else? And I think it's quite hard to continue doing your job on a regular basis if you're working under that level of anxiety. So I think our message to staff at this stage has been to keep thinking, and we've tried to demonstrate to them to keep thinking and to keep within the boundaries of the model. So we can react now to what's happening in the here and now, but we can also plan for later. We're very much trying to encourage staff to take study time so that they can plan for what may be coming in terms of the greater degrees of anxiety, health-related anxiety, potential trauma responses that we may be seeing in people over time. Having regular training sessions and increased levels of supervision will support people with this. And we certainly have our senior supervisors within the service designing various training sessions at the moment to make sure we're getting our staff equipped for what might be to come. And within that as well, there's the webinar series that starts next week around remote working with different disorders. And I think it's really important that as a wider framework, we all use that as a way of having a regulated response going forwards. Some therapists are reporting feeling de-skilled because they're not used to working in this way, and I think ensuring that they've got opportunities to talk about that and that we're giving them opportunities to skill up and feel equipped for what's coming. Having that level of equipment in terms of skills and training is just as important as having their laptop and their phone with them. In terms of keeping the team connected, we're having regular briefings with the team, weekly check-ins, ad hoc supervisions, drop-in sessions over lunch, and having chats running during the day with the team. So the things that people can drop in and out of, so people don't necessarily have to be there at a certain time, but just letting people know that we're there and we're available if they want to talk to us about anything. And clearly within that, there are some staff who've been very personally affected by the current situation within their own families, and we're needing to provide very specific bespoke responses to those people to support them through this current time. Still encouraging people to take annual leave as well is very important. It's very hard work sitting in a room on your own doing this kind of work, and so encouraging people to take breaks, even if it's not the annual leave they were expecting, is really important. We're trying to model collective leadership and having our senior supervisors picking up areas of responsibility and actually trusting staff to do what it is that they need to do. It's not the time to be punitive, it's not the time to be micromanaging people. I think everybody is under high degrees of stress. Some people are trying to homeschool their children at the same time as trying to work in the same house. And there are lots of other demands on us at the moment. So I think trusting our workforce at the moment and showing and modelling that compassion is a very important thing. So the final phase of this model is the recovery phase, and I think it's quite difficult to understand really where recovery will come from and when it will be. We don't know at the moment, as we come out of hopefully come out of the peak of the curve, whether there's going to be another one, whether there's going to be another surge in cases, whether there's going to be another curve coming later in the year. So it may be temporary recovery, it may be permanent recovery. At the moment, it's very unknown. But I think, again, it's about keeping thinking, what have we learned? If this does come back, what can we do more quickly and better next time? So we're thinking about helping people manage during the active phase so that they don't reach a phase of burnout or compassion fatigue. When we reach the recovery phase, we're thinking about potential moral injury as well. So potentially people who've had to make difficult decisions, and that's possibly more so for senior leaders and for physical health staff, but difficult decisions that perhaps have negative consequences. And also issues around survivor guilt, perhaps people who have survived certain situations when others didn't, perhaps people who weren't asked to do things on the front line when they felt maybe they should have done. So there are all of those kind of issues that are going to come up once we're past the active phase. And there will be fears about what if this happens again, because we don't know, none of us know, and none of us can assure each other that it won't happen again at the moment. Part of that recovery phase for IAPT service is going to be the move back to the office when that comes, and the move back to business as usual. And I guess we've been talking a bit about whether it will ever be business as it previously was again, or whether there will be permanent changes that come out of this in terms of working via technology. Certainly for our long-term conditions patients, there may be a lot more that we can now do, now that we have systems in place for video consultation that perhaps we couldn't offer to them before. But there will be issues with staff and with patients about, is it safe to come back to work? When will it be safe? And it may be a phased return in that some people will be asked to come back before others for various individualised reasons. And that may be tricky to manage as well within a team. But supporting staff with their own anxieties about that is going to be very, very important. Something that we're particularly thinking about doing at this stage, we've done it for quite a while in the service, but it's thinking about limiting the number of trauma patients that any of our therapists have on their caseload at any one time. We've always had a cap to that in order to protect therapists' wellbeing, but I think going forwards it's going to be even more important to keep an eye on that, to make sure that we don't have therapists who have up to 100% of their caseload of patients who've experienced trauma. Because the impact of that on the well-being of our therapists is going to be a big thing. So working with people to see what they feel able to manage and how they feel they'll be able to do that safely is going to be very important. We're in the process at the moment of looking at how we support our Step 2 staff with assessing some of the more difficult issues that may be coming through because of COVID, and ensuring they've got sensitive assessment skills at the ready. And thinking about having our more experienced staff doing those assessments with people where we know the issues may be complex and may be COVID related. So I think our peak may come later and our recovery phase may come later, and we don't know if that recovery will be temporary or permanent. At some point, hopefully it will become permanent and we'll settle back into business as usual. But I think at that stage, we still have to keep thinking about the staff and what they might need to support them to deal with the new caseloads of patients that are going to be coming through, I think, over the following weeks and months. I hope that that's been useful, and I hope that there will be some things from that you can take away and use within your own services. Hopefully there have been some questions coming in, and we've got a bit of time now that we can spend answering some of those, if that would be helpful.
Yes, so we do have a few questions. So to start off, we've got a question. So in Cornwall, our referrals are down by 75%. I imagine this is being seen across various other services too, and can definitely relate to feelings of what is coming for us all. Will we feel skilled enough to deal with it?
I certainly think, from my perspective, that there are also opportunities at the moment, whilst referrals are quieter, for us to think a little bit about preparation for what will be our active phase. And so we've been trying to look at what training opportunities there might be for staff. So we've put on specific CPD around integrating coronavirus into existing practice, identifying other training resources available that people can start to take study time for now, so that they can feel better equipped to handle any surging cases or new types of presentations in the future. So it is difficult when referrals are low, because often people feel, what are they doing? Often people feel anxious that others on the physical front line are working really hard, and then what are we doing here? But actually we know that our front line will come, and actually the best way for staff to feel prepared to deal with that, I think, at the moment is working as best we can with patients now, but then also looking at what training we can put on to give people the skills that they need to cope.
I think in addition to that, something else that we've done within the service here is started to think about different ways that people might be able to access the service at the moment. So I mentioned earlier about referrals being down and us having a concern that perhaps people don't have confidential spaces at home to call and talk about their individual concerns. So one of the things that the service has done here, one of our CBT therapists has designed a workshop, which is a wellbeing workshop, which we probably all have programs for around the country, but we've adapted it to incorporate anxieties that may be more present at the moment because of COVID. And that's going to be presented online. Now, we just require one member of the household to register to do that, but it may actually be a way of getting information out to people now that perhaps isn't personalised, but they may be able to watch it within a household. It may be a more acceptable way of getting that information discussed and spoken about, rather than somebody referring individually one-to-one for therapy. We've also put together some information packs of similar kinds of information that can be mailed out to people if they're not able to speak on the phone, so we can either email it or we can post it to them according to their preference. But I think it's just thinking about how we get that information out there now to people who may still be needing it but maybe just can't access for various reasons.
So someone's asked, what IT platform have you been using with patients? As a service, we have struggled to identify a suitable platform which has sufficient encryption and performance.
Okay, so we've been using MS Teams for all of our staff meetings and supervisions. The Trust is using a platform called One Consultation for video consultations. We're just in the process of having our waiting room set up now for that, for the IAPT service, but other services in the Trust are already using it. So that's the one we've been using. Don't ask me any technical questions because I'm not very good at anything like that, but I know some places have been using other platforms and some of them haven't been very secure, so I think it is something to be rightfully concerned about.
Someone's asked here, the PWP rollout is a stressful one aside from the pandemic. Do you think target pressures when things return to normal will increase burnout in the profession, particularly as PWPs are frontline mental health?
Absolutely, I completely agree. It is high pressure at the best of times, as you say, without this increased stress. And I think that's where supervisors and managers and leaders need to be protecting their workforce as we go forwards. I think it shouldn't be placed on our PWPs to have to manage that. I think you can only do what you can do, and maintaining staff wellbeing is the most important thing, because if we don't have our staff, then we don't have a service. So I think that's a conversation that leaders and managers within services need to be having about not passing that pressure down to the therapists, because it is something they don't need to be managing, in my opinion.
And just one thing I'd add to that, which is about trying to manage assessments when they come through. So we're aware that we might see an increase in very distressing assessments with people who might have had traumatic grief or post-traumatic stress. And so we're looking at trying to set up a system where we can both train PWPs in absorbing those and handling those sensitively and giving them the confidence to do that, but actually try and identify at a triage stage where there might be more complexity or trauma, and seeing where our step 3 therapists might be able to support by undertaking those assessments. So we're trying to kind of think carefully about what pressures they might experience, how we can support them, and how colleagues can also support them.
Someone has asked, could you clarify please what you have done specifically for IAPT high trainees? Okay,
well, all of our trainees, all of their situations have been looked at individually, as have the rest of the workforce, in terms of what their own specific needs may be. Where we've been able to enable home working, that's what we've done. For some of the trainees, they have preferred to remain part of the skeleton staff that's working in the offices for various reasons. And I think it's been important that we've been in contact with the university to ensure that they've got access to all of the remote learning platforms and they've got the technology they need to be able to carry on with their training despite what's happening at the moment.
So our next question reads, our PWPs have been redeployed to the mental health crisis line. We were told this was a national ask from IAPT. Is this wrong information?
I can't speak on behalf of the national team, but I don't believe that was a national request. That's not what I heard from the briefing that I'd heard from the national team, but it would be worth clarifying that directly, I think, because our PWPs haven't been redeployed in that way, certainly.
Yeah. So another question reads, we are all working from home with different clinic schedules. How can we all still feel connected?
I think that's a really, really important one. And I think this is where possibly having a rolling group chat going on something like Teams during the day is important, because different groups of people, hopefully nobody's ever lone working, so there should be different groups of people available at different times of the day. We certainly always have a manager on call for our late shifts. A couple of our evening clinics have stopped happening in the evenings now, but where we are working till 8 p.m, we always have somebody senior available on call if they're needed, to be part of those chats or for phone calls before people finish for the evening if needed. So I think it's worth finding out which of your colleagues are working at the same time of the day as you, and maybe setting up a WhatsApp chat group or using MS Teams. Or making sure people all take their break at the same time maybe, and they can just sit down for a cup of coffee for 20 minutes together and have a chat via one of the platforms. I think it's just about coordinating who you know is working at the same time as you and making sure you've got time to get together and just touch base and actually just sometimes talk about something that's not work as well. It's not always about discussing cases and debriefing the day. Sometimes it's just about having those informal bits of conversation that we have in the kitchen or in the corridor sometimes. And I think, you know, we should be supporting people to do that.
One of the concrete things that we do around that is a wellbeing hour for both Step 2 and Step 3 staff. So every month after a Step 2 or Step 3 meeting, we create an hour's space in that month for them to do whatever they want, that they feel is beneficial to their wellbeing. And that's something we've been really keen to ensure continues. Even though all of the changes in working requirements might feel like teams are pulled apart, those kind of collective spaces which are preserved for staff wellbeing are really important to be maintained, and that's exactly what we've done here.
So the next question is, our team are supporting one another brilliantly at present. We are all preparing for redeployment across other services, but are worried that the appropriate skills and training updates might not be one size fits all.
No, I think managing redeployment is a particularly tricky thing. And it will naturally lead to people feeling quite anxious about perhaps not having the skills they need for the job they're being redeployed into, and then potentially not having the skill set when they come back to IAPT either. And I think it's difficult to comment on different areas around that, because I wouldn't want to kind of comment outside of my own remit with that, because different places have different pressures. But I can certainly empathise with that feeling, and I think all you can do is the best you can with what you've got and where you are.
The next question is, my main feeling is a sense of home as my safe place and separating home from work.
Yes, I think that's a really big thing, and for some staff it's very difficult to sort of invite patients into your home, isn't it? If you're sat at home, you know, talking to your patients, or you're on a video link and they can potentially see part of your home if you can't blur your background or whatever. I think that is a very difficult dynamic to manage, and I empathise hugely with that. And I'm not quite sure what the answer to that is. I mean, where we have people who are finding that particularly difficult, we're trying to allow them to be part of the skeleton staffing in the office for at least a day a week, so that they have the opportunity to come away from that and to try and keep work a little bit separate. Obviously, we can't have everybody in the office all of the time, so I think that sense of boundary is very hard to maintain. And if it's your personal safe place and suddenly work is potentially intruding into it, it's quite a hard thing to manage. And I think maybe having an area of the house, if you're able to, that you work in, and an area you go to for your own personal life becomes very, very important. To have a physical distinction between the desk that you sit at to do that work and then somewhere else that you go to relax and have your own safe place.
The only things I'd add to that are about managing the day, so being very, very clear when the day starts and when the day ends, making sure that there are regular breaks where you can leave the space that you're working to get out of it, but also perhaps to arrange breaks at the same time as colleagues, so that there's an opportunity to touch base with other work colleagues to try and preserve those distinctions between home and work. We certainly know that some therapists have found this easier than others. We also know that for some people it may be difficult if there are other family members at home who have pressures or strains of their own. They might feel a burden to be thinking about both work and home. And that boundary can become tough. But certainly trying to think a little bit about the structure around their working day and protecting it how they can through breaks or other means, at least preserves the integrity as much as possible.
The next question is, how effective is the CBT intervention on patients who are currently going through the trauma experience, in particular the frontline staff who are having to deal with the large numbers of deaths due to COVID-19? Is the need to adapt the CBT model or just utilise the standard model?
I think we probably all agree that trying to do active trauma processing while somebody is still in the middle of the trauma is not the thing to be doing. And actually, although we've got to assess people on a case-by-case basis, I think until we get to the recovery phase of the model as a country, I think it's going to be very difficult to try and process anything right now for people, and there's a potential that we're going to make things worse for them. So I think for me it's very much about stabilisation and grounding, and enabling people to have space if they feel they need it right now, and just wait to see what happens in terms of processing.
So the next question is, and returning to it, what is the percentage of trauma clients that your CBT staff see?
So currently it's been 20 to 25% of the caseload. That was prior to COVID. We will obviously be looking at that and discussing it with staff to think about what the sensible level is going to be going forwards, but I can't imagine we're going to increase it hugely from there, just because we want to be able to protect our staff as they go forwards. The staff who are EMDR trained as well, that there are a few differences, but it's certainly been no more than 25%.
And the other thing that we have been doing is offering people who might pick up extra trauma work, or where there might be other difficulties, increased levels of supervision. So access to supervision space with a trauma specialist, supervisor and therapist, so that they can get close supervision with those cases, so that they perhaps feel more confident about how to work with trauma remotely. So there are those other additional supports around the structure and the relationships that we've talked about in the model that might support that work and ease some of the pressure.
The next question is, I am a trainee PWP, and on the first week of home working, I was told we would have a diary audit to check that we were keeping up. Majority of my assessments have been very distressing, mainly around sexual trauma, and my caseload has doubled. How can you ensure that service leads do not place increasing pressure on trainees to meet targets amidst a very unstable time?
That sounds like a really difficult situation to be in, and I think it's a conversation really to try and have with supervisors and managers if you feel that your caseload is increasing and it's becoming more complex, particularly if you're a trainee at this time, because it's going to be harder to train at home than it would be to train in the office. So I can only empathise with that situation, and I think it would be really helpful to try and have conversations within the service to express that and explain what's going on, because staff should absolutely be protected. It's what we were saying earlier about people should not be expected to do things outside of their usual remit just because some of those boundaries have blurred a bit in the current situation.
So we have just a few more minutes left. So one of the last questions will be, would it be good for you to do a session on the sensitive assessment? So
is that asking whether we would do a session on that?
Yeah, I think so.
We can.
Yeah, we can.
If somebody would like us to, we certainly can.
Are there conversations happening for more resources and more specialised training post-COVID-19 with NHS England and commissioners?
I think we can predict some of it. We can't predict all of it. So again, it's going to be a case of seeing how we go and developing new resources and new training systems, I think, as we move through the next few months.
As a second to last question, are you providing any support to the physical health frontline staff linking up with the health and wellbeing team in your local hospital?
Yeah, so we've had conversations with certainly emergency workers within the area have been in contact with us, and we are prioritising those people. If they come into the service at the moment, they are becoming priority patients, and the same will be true for physical healthcare colleagues if they access the service. So our services are fairly well known in the local area anyway, because we're within the same trust as a lot of the physical healthcare services. So people know that we're here, and we're continuing to reach out to them to let them know that we're here. But obviously there is also the 24-hour helpline within the trust that people are able to access as well if they need to.
Mm-hmm. And then as the last question we have, what impact do you think redeployment will have on IAPT clients and staff fulfilment?
I think it's a very tricky one, and I think people are redeploying in different ways. Some are just closing to new referrals and continuing to work with existing patients. Some have stopped completely and redeployed all staff. And I know the message from the national team has been that IAPT services should continue because we are needed, we will continue to be needed hugely, and we need to prepare for what's coming. So I think being able to support staff moving in and out of IAPT services is crucial, so that they don't feel that what they were doing before wasn't important in some way, because it's very important. The work that's happening in IAPT is extremely important. I think some places have had particular pressures where they've had to make certain decisions, and that may well be understandable within the context. But I think we have to think carefully about when IAPT services reopen again, where they have closed, and the messages that are given to patients at that stage. That, you know, we need to be clear with them about why it happened, and what happened, and the fact that things are now back, and try and repair some of that break that may have happened with them. Because certainly for me, if I was a patient in that situation, I think I'd feel quite disgruntled, and I think that would be understandable. So I think we've got to acknowledge that with people, and try and help them understand as far as we can some of the decisions that have been made, and try and encourage them to come back and work well with us, you know, whenever we're able to do that.
Thank you. I'd like to take this time to thank Sarah and Brian for your time. It's been a really insightful and useful presentation, and I'm so glad that we were able to work together on this. I'd also like to thank ICS Digital Therapies for supporting this webinar and helping to make it happen. Lastly, SBK Healthcare would really like to thank everyone who's working so hard. From the bottom of our hearts, it is humbling and amazing how much work, time and dedication you guys are putting in right now. It makes us so proud. Thank you. Goodbye. Hi everyone. If you like this video, please do give it a thumbs up. Subscribe for latest content and make sure that the bell button is turned on so that you get a notification when we next upload.